Thank you very much, Deepak, for this introduction. It's a pleasure to be with you today and to discuss what I think is an exciting topic. About 15 years ago, I decided to move my investigational approach from disease to health and trying to understand health. And what I'm going to be talking today is healthy or subclinical vascular disease in the heart and in the brain. When you approach this subject, you realize very quickly that there are 3 different ages in which health is different. From birth to age 20, from age 20 to 60, and from age 60 to 100. This is in 3 circles, the 3 ages, and I'm going to be talking about one subject in each age. We'll start with the PESA study between age 20 and 60. I will go into the brain between age 60 and 100, and I will end up with children from birth to age 20. Let me begin by saying that the main challenge that we have between age 20 and 60 is to know whether we have arterial disease or not, coronary artery disease. So we got about 15 years ago into the issue of imaging. And the question is, can we do imaging technology that can be applied to the world, not just to the individual patient who comes into a hospital? We developed the so-called PESA study. This is in Madrid, which is a study of 4,200 people over a 20-year follow-up, and we follow them every 3 years. What we do? We do imaging technology, which is certainly the peripheral vasculature with 3D ultrasound, iliofemoral region and the carotids. We then do CT for calcification, and recently CT angiography at the same time. And then we have MRI and PET of the large vasculature. And we look at the body in itself and then the brain. And then we approach this trying to say what relationship has with 4,000 parameters, which we use AI in terms of risk factors and this technology, and then multiomics on every aspect from genomics and so forth. Well, having said this, let me go into the critical technology that we developed and is now fully validated. And that is, this is basically a device, a 3D, that you put in the neck, iliofemoral region, and artificial intelligence tells you where the lesions are. And then you move, and artificial intelligence tells you what is the volume of the lesion, and this may appear in your phone, exactly what the volume is. You don't need technological expertise for this. We developed this in Madrid, and now it's being used here in this institution in the so-called PRICAT study. This is the basic technology of imaging. This is the PESA study, and actually we started 15 years ago, and the results are all coming in the last 2 years. And in green is what I presented here about a year ago. In red is what is new this year. The disease begins at age 30, particularly in the iliofemoral region. It progresses 33% every 6 years. Long-term risk factors in a young have much more impact in the reactivity of the arterial system than in the elderly person. A cholesterol that is high at age 40 has much more impact than at age 70. Well, all of this is actually in the references system that you have here. Then short-term, if you put your device at age 50 or 60 in the iliofemoral region or in the carotid region, what about cardiovascular events and mortality? We have the data, the bioimage, very, very related, and this actually was published very recently. What I want to emphasize today is what is new. What is the relationship of what we do that we think we can apply globally in high, middle, and low-income countries with coronary artery disease, and which have the data? The importance of microvascular disease, and finally, inflammation in the bone marrow. Let me begin to go into the study we just finished. This is a study of near 600 individuals that we look at first whether there was coronary artery disease at CT angiography. Mild or no disease, mild, moderate, and significant, more than 50% stenosis. What is in the abscissa? No disease in the carotids or iliofemoral region, carotid disease, femoral disease in both. Look at here. If you have disease in the carotids and iliofemoral, you have a 75% chance that you are developing already coronary artery disease. The other way around, if you don't have disease in the carotid or iliofemoral, the chances of having significant disease in the coronary arteries is close to zero. So we are talking about a technology that is quite valuable in understanding if we are developing the disease or not. And if you have to summarize the data, carotid and iliofemoral disease actually are strongly correlated with early subclinical disease in the coronary arteries. Particularly, they are additive if disease in the carotids and iliofemoral are both present. What's very interesting is you rule out coronary artery disease of any significance if there is not by 3D ultrasound disease in the iliofemoral or in the carotid region. Most importantly, coronary calcium score didn't work in young people. And that is about 60% of the people who were developing early disease was zero, the calcium score. And you know why? Because calcium score is a healing. In an early age, what we are talking about is the development of the disease. So there's no time yet for calcium to take place. I think this is very important. Having said this, let's now move into the microvasculature. We all know what the microvascular is, but what I'm going to present to you is quite interesting. This is actually in about 900 people. And what we did is first, risk factors that can lead to subclinical atherosclerotic disease in the carotid, iliofemoral, and coronaries. But also at young age, between age 40 and 55, we see a lot of microvascular disease when we use magnetic resonance imaging and reserve, and myocardial reserve. And this is fascinating because it's not transmitted clinically. But you will see later on when we talk about the brain, the importance of this aspect of the microvasculature in cognitive dysfunction. I will be discussing this in a moment. And then the question of inflammation. We all talk about inflammation, but you know what we are talking about, the bone marrow. The inflammation comes from somewhere. And this is actually what we did, positron emission tomography, and this is very well validated across the world. And you can see how the bone marrow is activated in blue. And this is the large arteries, carotid or iliofemorals. You know what is in yellow here? Is the combination of monocytes and cholesterol. So you see activation of the bone marrow, you see disease peripherally. Well, the interesting aspect is what this has to do with acute coronary syndromes, with CHIP, that is mutations of the bone marrow, and with the risk factors that we talk usually. Well, let me talk about, first of all, about the acute coronary syndromes. What you see here is with PET, is the peripheral disease, which is the combination of cholesterol and monocytes. And that's very interesting with PET. But you might see with MRI fibrosis, this is when this is healing. No problem. Now comes, this is what we call actually compensated, and that is the so-called fatty streaks that were seen at autopsy. They become fibrotic lesions. And with two different technologies, you can see that. The problem is when the substrate is very significant, the monocytes commit suicide. This is apoptotic phenomena. And they release cytokines. You know the two most important ones? Metalloproteinases, which may lead to plaque rupture, and tissue factor, which may lead to the thrombotic phenomena. In fact, we believe, and now very strongly, that some of the acute coronary syndromes, perhaps most of them, is a decompensation between a risk factor, between a defense mechanism that decides to kill itself and the development of cytokines that actually make a devastated process in the artery with plaque rupture, metalloproteinases, and tissue factor causing the thrombus formation. This is about the acute coronary syndromes. But the question is the lipids the only attraction for monocytes? And it's not. In fact, here is we look at the volume of plaques, and here we see the relationship between plaque and you have LDL cholesterol. But you see there are other factors that are inflammatory, like fibrinogen and white cell count, that actually are even more significant. What it means that you may have a pro-inflammatory process that is not only guided by cholesterol, asking the bone marrow to help. And that's the issue that leads to CHIP. CHIP are mutations of the cells of the defense mechanism of the bone marrow. These mutations in 20 to 30% of the adults. This is very fascinating because this is a pro-inflammatory process when there is such mutations. Particularly, these are the two genes that are mutated, DMT3 and TET2. This is what we found in the PESA study, okay? So the question is, what these mutations have to do? And since we follow individuals every 3 years, we now have the data, and this was published in Nature Medicine very recently, and that is the mutations take place before the plaque develops. So there's a pro-inflammatory process that leads to plaque formation and actually trouble. How this means clinically? You go to the TIMI trial. 5 TIMI trials show the relationship between CHIP and cardiovascular events in the upper line that you see in the slide. But there's even more. About a week ago, this was just published in the women's study. Exactly the mutations that we found, TET2 and DNT3A, are actually, they are very significantly correlated with coronary artery disease. So what I'm saying to you is we see many patients with no risk factors, but the risk factor is actually a genetic problem, and that is the bone marrow is affected by mutations, and you have a pro-inflammatory effect that has nothing to do with the conventional factors that we have today. This will be, CHIP will be very easily measurable probably within the next year or two, and will be part of the testing that we do in patients. Now, finally, risk factors. We all thought hypertension is a hit into the vasculature, the endothelium, but my friends, it's much more complicated. What we are finding is in the metabolic syndrome here, or even central obesity or hypertension, you see in blue, this is the activation of the bone marrow. And what we are seeing is that the risk factors that usually think they have an effect directly to the artery have a pro-inflammatory effect that goes to the bone marrow. And we see this with positron emission tomography. But this is actually not the end of the story. We're now working with the group at the Mass General. We have now data indicating that you can have a sedentary life or you can be activated. With sedentary life, positron emission tomography is activated in the bone marrow. With the life is being activated, you don't see that. This is very fascinating. What I'm really saying is the bone marrow is critical here. For acute coronary syndromes, for CHIP, a genetic problem, and finally for what we talk about the conventional risk factors. So as we remember, when I started platelets 50 years ago, and nobody believed on platelets, only the hematologists, I can guarantee to you that all of you will be talking about the bone marrow in the next 3 to 5 years. This is my prediction based on the data that we are presenting. Well, this is all in terms of disease in the heart and in the vasculature that between age 20 to 60. This is what we have learned, and I think is fascinating, the microvasculature, the relationship between external imaging and coronary artery disease, and finally, what we have been discussing on the aspects of the bone marrow. Well, this being said, now we are beginning to understand the disease much more by going into health. But what about the brain? So all the technology I presented and more, we have used it in the brain between age 60 to 100. And I will be presenting 3 topics. First, the relationship between risk factor profile and cognitive dysfunction and Alzheimer's disease. Then I will present the issue of coagulation in the brain, which we didn't think was a problem, but it is in patients with cognitive dysfunction and Alzheimer's. And then finally, I will present chronological versus biological age. These are the 3 subjects we have been studying. First of all, there is data already evolving very rapidly that the risk factors that affect the heart also affect the brain. And we have a paper coming out in the next few weeks pointing out how significant is the literature in this regard over the last 3 years. Well, it's a pity. I don't know what happened with the slide here. But basically, here are the risk factors that we usually talk about cardiac disease, but there is diabetes, and then there is hypertension and hyperlipidemia, very important in the brain. You know, this is education, poor education. And this is actually, is at the end of life, what really is the aspect of whether you are active physically or you are not active physically and mentally. Here you have it. So these are the risk factors, this is early life education, and here is actually isolation and lack of motivation. You know what? This is all critical in cognitive dysfunction, as I will be presenting in a moment. So this is the study as we started with about, I think it's a large number of individuals in which they had 2 of the 3 risk factors we mentioned, either diabetes, high cholesterol, hypertension. And we followed them over 6 years. This is the positron emission tomography entry of glucose into the brain. This is 6 years later if you have such risk factors. And this is now correlated with decreasing flow by MRI in the brain. And the question is, where is the problem? I think the problem, as you will see in a moment, is in the microvasculature, intimal thickening with the risk factors that affect cardiac disease. And this is actually very interesting that we are now testing this in the PESA brain study. This is a study of 1,000 people that we use all these technologies in the middle. Obviously, we look at cognitive function, and then in the blood, there are now biomarkers. As we use troponin for the heart, we now have NFL, GFAP, and so forth, affect slight injury of the brain. You see these biomarkers in the blood. Well, this being said, our hypothesis is very simple. We believe that the conventional risk factors, and particularly those that I mentioned, diabetes, hypertension, not well controlled, and hyperlipidemia, affect the microvascular of the brain. But you know how, when we talk about intimal medial thickening of the carotid arteries, this is happening in the brain. It's not necessarily atherosclerotic disease, but you see how MRI flow decreases with these risk factors, and then you have a problem with the uptake of glucose into the brain. We think this is the origin of a lot of senile dementia related to risk factors, and this is what we are addressing. And now something that you should be aware of. These biomarkers in blood are now providing a lot of good information. If 2 of these 3 biomarkers are present, the chances of having actually cognitive dysfunction are over 50%. If you don't have any of them, the chances are close to 0. Now, this is very expensive stuff, so you cannot just do these biomarkers. We have a grant, and it's a lot of money. It's just in measuring biomarkers, very, very expensive today, but certainly with a tremendous future of what we are talking about. Well, this being said, now still within the brain, there is hope. I don't know how old you are, but you might be age 60 or 70, and you may say, too late. I already don't recognize my brother. Just a moment. Here's the story. There are 3 studies that are quite helpful and hopeful. The first is the US Pointer study of 5 centers, patients at risk or individuals at risk of cognitive decline and dementia. This was a structural approach of intervention. Very interesting. This had to do with taking care of the risk factors and at the same time taking the patients out of isolation. Social isolation is critical in cognitive dysfunction. And another factor is lack of exercise and lack of motivation. Well, they look at all of these and they found greater benefit of global cognition with a structural intervention. I don't present you the data, but similar data just came out, and this was published also in the United States, doing exactly the same thing, but with people who have mild cognitive impairment or early dementia. And they found exactly the same story. After a couple of years, you see stabilization or even improvement in the cognitive dysfunction. Remember, risk factors, isolation, exercise, and motivation, making your brain to work. These are critical issues when we talk about this aspect. And all the studies are beginning to show the same. This is a fascinating study in China. Uncontrolled hypertension, 33,000 people, they were randomized, treating the blood pressure very aggressively. They were able to drop 22 millimeters of mercury. All-cause dementia was lower in the intervention group. Very interesting data. What I'm really telling you is that the risk factors that affect the heart are affecting the brain. And if we don't believe that, we are not really good cardiologists. We should really move from the heart to the brain because it's a similar situation. Comes a little bit later in life, and the microvasculature appears to be critical. The second issue about the brain is clotting. Well, we published this in 2024, but our work began in 2019. and very basically was in the mouse model. The concept is that one of the aspects of dementia is clots in the microvasculature. And you say, where this came from? This is actually the first study that we published in 2019. And this was in a very well-known mouse model that develops Alzheimer's. And the mouse model at autopsy, post-mortem, was small clots actually coinciding with the beta amyloid in the microvascular of the brain. And when we gave dabigatran at the same levels in blood that we see in humans that are treated with dabigatran, with atrial fibrillation, no clots were present. And actually, it was complete stop of the Alzheimer's phenomena in the mouse model. This was the beginning in 2019. But this has progressed significantly, and we have submitted this actually a week ago for publication. And that is, we are now able, in vivo, in the same mouse model, through positron emission tomography, to identify fibrin. And that is, in 24 to 48 hours after injection, you can see the identification of fibrin compared with controls. And this is, you see the images. This is the fibrin, actually, and this is the color, and this is the control group. And this is fascinating, because we are now able to detect clots in the brain through positron emission tomography. But there is more. What about humans? And this is the data that we just obtained, in which we can compare the identification of fibrin in the brain, and here is in the abscissa, in the right side at the top. And then in the vertical axis is the platelets. They are all correlated. And this is actually at autopsy. It was just labeling. And here is the blood clots in terms of fibrin in the brain at autopsy of humans with dementia. What we are really talking about here is something that is completely new, which is leading us to develop a significant trial of anticoagulation for the prevention of cognitive dysfunction in Alzheimer's. These are very complex diseases with many, many factors, but I am trying to tell you we're beginning to see the importance of risk factors, the importance of clotting, and so forth. Well, this is the story about the clots in the brain. Finally, talking in the brain, I said that I'm going to call chronological versus biological age. All the newspapers and the televisions talk these days. Somebody died at age 2007. Well, look, I will tell you the data that is fascinating, that is evolving. Is your age really your chronological age, or you are younger or older biologically? That's the question. Well, the story is evolving very rapidly, and I think it's important to realize the following. The concept is beginning to be understood. There is a methylation of the components of the cells that lead to cytokine release. Bad news. It's like the apoptotic phenomenon of the monocytes. These cytokines affect all the other cells. Then the cells are not able to proliferate. This is the cells in the body in general. And actually, there is a question. Even if they proliferate, the telomeres are getting shorter, which is the supply of DNA in the moment of proliferation. So you have three aspects that in the literature are becoming very critical when you talk about chronological and biological age. And that is the basic of biological age is whether the cells are viable or not. And the issue of methylation, the issue of cytokines, and the issue of telomeres are being investigated very aggressively. Well, today we can measure methylation. The evolving technology is now with us. But interestingly, if you go to the brain, you can already begin to say chronological versus biological age. Here it is. The biological age is getting significantly handicapped if you have thin cortex here. If the volume of the gray matter of the brain is decreased, and if the density of the white matter is increased. So now the research of people working on methylation and telomeres in chronological age are beginning to realize that imaging of the brain is another parameter that you can look at. And this led to the cover of Nature Medicine actually last week, which is fascinating. This is the cover. And this is basically a young guy who is not exercising at all. He's all the day in front of the computer. And this is what in the future, everything that we are now measured, it will be measured. And this guy who appears to be young is actually pretty old. And I think this is evolving. So what I'm really saying to you, we have talked about mortality for a long time. We have talked a few minutes ago about cognitive dysfunction, but now we're talking about chronological age. What I'm really saying is all this new technology is evolving from the heart into the brain, with aspects that are different and different ages, but I think are equally important. And now the interesting aspect in industry is that the sirtuins actually is a family that actually has a lot to do with the methylation of the cells that tend to the cytokines and the shortening the telomeres. So the question is, can you enhance sirtuins pharmacologically to make a biological age longer? And that's the issue that is now being entered into industry. I finish in the last 5 minutes about something we have been very intrigued. And that is all of what I presented is exciting, very exciting, at least to us it is, because it's really breaking through what is health and how we may prevent disease. But the question is education. And here is the issue that I want to talk about finally. This actually came out in the Lancet Commission that was published a few weeks ago. And if you read, adolescents are the future leaders of our world. We must ensure their health and well-being to secure a more just society and a healthier and more productive planet. The future of the young people, whether we like it or not, that's what it is. Now the question is, what do you do about it? And actually, this graph is presented, and it's a fascinating graph because you can see that if you do something before age 20, you may have an impact on these people. The question is where this data comes from. Well, I don't have to go into the details, but I have to say that I have a brother that has contributed significantly to the field. He's at UCLA in Los Angeles in neuroscience. And basically, this is the concept. And when you are young, under the age of 20, you have the receptors of the brain are in number is relatively small. And then what happens is whatever you tell a child, particularly under the age of 10, it sticks there. And it comes out when you are an adult. Just look who are you today, and you will remember how important were the first 10 years of life, your environment. That's the issue. What happened later on, everything gets dense, the connections between the receptors is very high, and whatever you tell a guy from this ear gets out in this other. Because it's very complex, it's very chaotic. So the question is, can you infuse health at young age? That's the question, based on this biology. And so we developed 4 programs in over 7,000 children, all randomized, in which one group was actually intervened, how the body works, food habits, physical activity, to control the emotions, to tell them you are in charge of yourself when somebody brings drugs, when you are older and brings alcohol and so forth. Self-esteem, very important. And then these things is done. These 4 aspects are presented over 6 months or in 60 hours. And the other groups serve as controls. 4 randomized studies. The first one was in Bogota and Harlem, New York, 2 completely socioeconomic entities, very different. The results were fantastic at 2 or 3 years of follow-up in terms of knowledge, attitude, and habits in the group that served being intervened versus the group that served as control. And the same in Harlem. The total of children that were intervened in both aspects were close to 2,000. This just came up last week. For the first time, the global prevalence of obesity has surpassed that of underweight among children and adolescents. This is across the world. And the main reason, unhealthy food environments. I don't have to get into this, but that's the problem. Now, here's the issue. The children that we did in Harlem and Bogota were 3 to 5 years of age. You cannot measure anything, obesity and so forth. You can only go knowledge, attitude, and so forth. So we went into all the population. Most of the children we intervened within 8 to 10, near 2,000 children in Madrid, Spain. And they were randomized into exactly the same process I mentioned before. What happened 3 years later? This is the quantification of fat by the most modern technologies of fat identification. This is BMI in the control group, in the group being intervened. This is the circle of the abdomen, the control group, the intervened group. And this is the relation of the height and circle of the abdomen. Trying to say you, for the first time, a study shows that in young kids, you can have an impact in terms of obesity and fat deposition. And I think this is very exciting. But the third project is interesting. There are not always good news in research. What we found in the group of Bogota, that is the first that we intervened, is that if they really were compliant to the intervention, they did very well, but those who didn't comply didn't do too well. But bad news at 10 years. They were intervened at 3 to 5. 10 years later, we went to them and said, how you are doing? Bad news. There was no difference between the control group and the intervene. And we say, maybe we have to do something about it. And we found that adherence was important, but most important was reintervention. When we reintervened, here in blue, the group that were intervened before, the results are exponential. So reintervention is critical if you want to have some effect. And in us as adults, we have a lot of data, not only on health, on everything else. If you are up there, if you not reintervene, or you don't do something about it, you will go down. So I think it's an issue that we see in children that applies to all life, but it's very fascinating, the issue of intervention. We have good data until age 16. We don't know more interventions later, or how long you have to do this. And the final study is the control groups did reasonably well, much better than would be expected. Why? Because if you go to a school and you intervene, the control group is in an environment of intervention. They begin to take care of themselves too. So we found the importance of the environment. And this led actually to the family project. And this is fascinating. We now get into families with the 4 aspects that I mentioned before. But here the intervene is the parents, the children, and the grandchildren. And actually the results are fascinating when the environment is involved. So this is much better than just go into a school system. But even more, in Colombia, I think in 2 or 3 countries in Latin America, we went to the waiting rooms of the doctors and we put a video. Do you want to participate as a family while they wait there to be seen? And they check up. The results are fascinating. What I'm saying is this is leading to something that is very interesting, and I'm going to finish. First, what we have learned with children, over 7,000 children, all randomized. By the way, today we are working with 50,000 children around the world, all randomized study. Adherence is critical. The environment is critical. The sustainability with intervention is critical. What is this question mark? How these kids are going to be at age 60? How many times we have to reintervene? We know now until age 16, but we don't know later. I mean, that's the key question. And this leads to something that the American College of Cardiology made a decision very recently, and is to work between 26 to 35, a roadmap in which I will be really driving primordial prevention across the world by training cardiologists and physicians to work in their communities and to work in their environment, to teach what we are teaching and see if we can have an impact by dealing with children at different ages and having an impact on health. This is actually a last statement of the last commission that I presented to you a minute ago about children, presented in the Lancet. The investments made in this generation of children and adolescents will determine human and planetary futures for good or for ill, and the time is to act now. I just finish by saying to you the following. I try to present to you something that to me is quite very important of all of us who deal with medicine and cardiology, and that is to take into account there are 3 H's. Imaging is evolving. It's evolving in the hospital, but it's also evolving globally. We are really moving globally with this technology that I presented to you. The brain, we cannot disregard the reality. The brain is being affected by the same aspects and risk factors that affect the heart. In addition, isolation, poor education at young age, there are other factors, and the issue of clotting is also evolving. And finally, if you're asking me, what would you like to do in the future that might have impact in terms of health? I would go into childhood. That's basically what I reached after many years of working all sorts of things about clots, coronary arteries, and so forth. This is prevention, but rather than prevention, I would call it education. Thank you very much. I think you can leave it. No?
Do you want questions now?
Okay,
or will we
no
go-
problem.
Okay, so let's take some questions now. And anyone that has questions, please use the Slido so we can get through them efficiently. There's some great questions here. But before I get to the questions that people ask, I actually have to ask a question. That was really outstanding. I'm sure everyone in the audience feels that way. And it's incredible what you're personally doing for health right from infancy all the way to the end of life. That's remarkable. I don't know anyone else that's doing that sort of thing. So you talked about dementia. I'm going to talk about that end of life because, perhaps people in the audience here are more worried about that end of the spectrum than the beginning end. You mentioned things like lipid lowering, the microvasculature, blood pressure control as ways to reduce the risk of dementia. And that's something that everyone here, of course, can do and can help with. But you also mentioned another pathway to prevent dementia, which is a bit harder, that is preventing things like social isolation, engaging older people. How do you see bringing all these together to actually make an impact on dementia, which around the world right now is, it's a real crisis. People are living older. There's a lot of folks with dementia.
Yeah, I think isolation is becoming, it's in the literature. In the last 3 years, the literature is evolving very rapidly. How can you change isolation? Society has to be aware that isolation is a problem. It's a culture that we have to learn. Once the culture is there, I think we can make a change. On individual basis, you can certainly work in your family. I was actually very interesting. My father was a psychiatrist, and he always told me, as older you get, be sure you are always motivated. And I say, why? Because your brain will be clear. This was my father was a psychiatrist. And I think he's right. It's now becoming very evident that it's not only the isolation, but you have to be motivated. Your brain has to work. You cannot go home and go to bed. You just have to do things that motivate you. This is a very important issue. And the other one that is evolving is education at young age. And that is whether you're highly educated or not. How you change this, Deepak, I think is a matter that we talk about it, and that's why I am very happy to be here, because there are people who can have influence to people and to develop a culture on this. I hope it will work. May take 10, 15 years, but I think the culture will come.
Yeah, no, really helpful answer. Terrific. Thank you. So let's just go through some of these questions here. Maybe we can start with this one on clots in the microvasculature. I was wondering about that too. You showed some intriguing data there. But is any implication of that, for example, if someone has atrial fibrillation, they're taking an anticoagulant, does that, of course, it lowers the risk of stroke and it reduces the risk of stroke-associated vascular dementia, but how about the risk of cognitive decline in general?
Atrial fibrillation, unfortunately, dementia has been pointed out in the literature, cognitive dysfunction with atrial fibrillation. And the whole thing there are microclots, I believe. That's what you see with MRI. And that is, you may give anticoagulants to a patient to prevent a stroke, but I'm not entirely sure you are preventing the very tiny clots that may go to the brain. This is my interpretation of the dementia in atrial fibrillation, but I think the question of anticoagulants is becoming an issue in cognitive dysfunction, and we are now in the process of developing a huge trial that is addressing the issue I was talking today about the small blood clots. I believe the blood clots have something to do with the risk factors. I don't want to get into this, but I think this is my feeling. So we are dealing with risk factors, and maybe we'll have to deal with anticoagulation.
And this question about the bone marrow inflammation, how much exercise and what type would reduce bone marrow inflammation?
Well, we don't know. Actually, we are working with your friends in Boston on this. We don't know how much exercise, but we have already data in PESA and in Boston independently that exercise makes a difference in terms of the bone marrow activation. It's much less activation of the bone marrow with significant exercise. I cannot quantify, because we are going over the manuscript, I cannot quantify for you how much exercise it makes a difference.
Sure. Now, but for, at a minimum, one can state that exercise is beneficial among many other reasons for reducing inflammation as well. Any thoughts about preventive screening measures such as bone marrow PET? I don't know that I'd really call that a preventive measure, but bone marrow PET or biomarkers on screening?
Not really. Frankly, in the future, I see to put the device, you don't have to be an Einstein. Put the device here and there, and the phone will tell you if there is disease or not. The highest risk factor, and we have a lot of data, is if the disease is there. That's the highest risk factor. That's why also calcium score is important, in the older people, I believe, and you will hear this in a few minutes. But I think these are issues that are easy to do and so forth. I wouldn't go in terms of biomarkers to try. I don't think we reached that stage yet. This is all investigational.
Yeah, absolutely. The FDA, with respect to Alzheimer's, did just approve a biomarker for looking at that. But yeah, much of this is investigational. And I think the final question we'll take here is just the bottom one. How young should cardiologists start screening for patients for subclinical athero, whether it's calcium scoring, although you pointed out the limitations already of calcium scoring in the young, lipoprotein analysis, or 3D ultrasound?
Frankly, age 30. There are some people who develop disease earlier with familial hypercholesterolemia and so forth, but in our study of over 4,200, well, actually we have done this in 12,000 people now, is age 30 is the time to start, because this is when the disease begins to start. No? So I think the guidelines, all these the guidelines at age 50, Framingham, this is fine to me, but it's old. What we have to do is much earlier, imaging, and then at age 30, begin to do our job if we can. The only problem, and I finish, is that hypercholesterolemia at age 34, 35, the young people don't like to take a statin, so we have to take another approach.
Yeah, well, even the older people don't like to take statins, is the truth. Thank you so much. That was really brilliant.